Salamat. welcome to all the delegates and faculty members to this very unique no thrombosis concept. So I am Lakshman Patil and I welcome you all to this no thrombosis case study presentation. So no thrombosis is a live workshop where we do discuss real life challenging cases of clinical cardiology, particularly related to patients with CAD, PAD, DVT, PAF, and COVID-19 coagulopathy. So this platform has generated a lot of interest amongst doctors, and I'm very happy and proud to announce that we have won 9th edition of SIMS Healthcare Excellence Award in year 2021 for most engaging scientific platform. So all the credit goes to doctors like you who have been taking a lot of interest and attending no thrombosis sessions. So we have today Dr. Professor S.C. Manchandana sir, who is our course coordinator for today's session. I think sir doesn't require any introduction, but for the sake of tradition, it is my honor to introduce our course director, Manchandana sir. Sir is consultant cardiologist at Sir Gangaram Hospital, Delhi. He is a senior consultant and coordinator of DNB programs at National Board of Examination and a former professor and head of Department of Cardiology at All India Institute of Medical Sciences, New Delhi. Manchandana sir has he has 36 years of experience at AIIMS, and then he is superannuated from the institute in year 2003 to join Sir Gangaram Hospital in the Indian capital city as a senior consultant. Professor Manchandana sir has presented numerous research papers and has written several journals. So I welcome you, sir, for this session.
Thank you.
And yeah, we have been joined with Dr. Rajiv Kumar Rajput sir as one of the moderator for today's session. Dr. Rajiv Rajput sir is one of the most experienced cardiologists in Delhi and currently associated with Apollo Hospital. His special interest lies in taking cases of enhanced external counterpulsation and other novel chest pain therapies, balloon valvulopathy, coronary artery disease, as well as interventional cardiology. Sir has trained in premium institutes of India and abroad and is highly recommended by his patients for exceptional cardio care. He has authored multiple research studies in his more than 2 decades long career and has contributed greatly to the field of cardiology and intervention cardiology. So I welcome you, Rajput sir, for this session.
Thank you.
Yeah, we also have been joined by Dr. Nagendra Singh Chauhan sir as our second moderator for today's session. Dr. Nagendra Chauhan sir is a senior director, interventional cardiology at Medanta, the Medicity, Gurgaon. Dr. Nagendra Chauhan sir has done super specialization in cardiology and postdoctorate fellowship of National Board in Interventional Cardiology and Electrophysiology. He has gained further experience in complex coronary interventional, structural heart disease intervention, and percutaneous aortic valve implantation at Mayo Clinic and Cedar Sinai Hospital in USA. Dr. Chauhan sir has 15 years of experience in teaching undergraduates, postgraduates, and fellow in cardiology and interventional cardiology. So I welcome you, Nagendra sir, for this session. To make this session interactive and interesting, today we have joined by Dr. Nabjit Talukdar sir, who will be our speaker for today's session. A few words about Talukdar sir. He has completed MBBS, MD Medicine and DNB Cardiology and FESC. Sir is presently working as a senior consultant interventional cardiology, electrophysiology and pacing at Batra Hospital and Medical Research Center. Talukdar sir has published many articles in national and international journals, and he has participated as a faculty in national and international conferences, webinars, and symposiums. I welcome Talukdar sir for this meeting. And today's second speaker is Dr. Harsing Singh Bhatia sir. Sir has completed MBBS, MD Medicine, DM Cardiology. He is presently working as a consultant cardiologist at Metro Heart Institute, New Delhi. Sir has published more than 15 articles in national and international journal, and he has participated as a faculty in national and international conferences, webinars, and symposiums. So with that, I would request our course director, Dr. Manchandana sir, to take the proceeding forward. Over to you, Manchandana sir.
Thank you. Am I audible?
Yes, sir.
Well, friends, I think it's an honor to be the course director of this symposium on no thrombosis. I think this is a very important forum for all the practicing clinicians because thrombosis has become the leading killer of mankind. Actually, thrombosis was made by nature as a protective phenomenon. Whenever the ancient man used to, say, fight the animals or he was staying in jungle, he had some bleeding, etc. So thrombosis used to occur and protect him from bleeding to death and all that thing. But over the years, this thrombosis has become the biggest enemy of mankind. I think this is because of our unhealthy lifestyle. The thrombosis has started occurring at many places, both in the arteries as well as in the veins. And as I was saying, it has become the leading killer of mankind. If thrombosis occurs, say, in the coronary arteries, we get coronary artery disease, heart attacks. In the brain, cerebrovascular accident, the peripheral vascular disease, and so on and so forth. So in the arterial side, it has become really a big problem. On the venous side also, there is a big problem, this venous deep vein thrombosis and pulmonary embolism. Again, both coronary artery disease and pulmonary embolism are leading killer of mankind now. So I think too much of thrombosis has really also become a real challenge. But fortunately, we have drugs which we can fight with this thrombosis and all that. We had, of course, antiplatelet drugs initially. They were good for prevention of sort of coronary artery disease, arterial atherosclerosis, etc. But then came the antithrombotics. Initially, they were the vitamin K antagonists, and for a long period of time, we have been using them like warfarin and acetone, etc. But there was a lot of problem in using these drugs and all because one had to use the INR properly, and the patients found it very difficult to maintain a proper INR. But fortunately, in the last about 20 years, we have got these newer novel oral anticoagulants and all, and which have really made our life very easy. And it has these what are called DOACs or direct oral anticoagulant drugs. They have really made the life very easy, and I think have been responsible for saving large number of lives. We all know that NOVAX have been used for prevention of, say, thrombosis or embolism in the case of atrial fibrillation. Atrial fibrillation has really come into the forefront in the last few years. In my time, I've been in practice for the last 50 years. We never had any treatment for atrial fibrillation. We used to just manage the heart rate, etc. And as I said, the VKA were not very, very useful. But now I think the life has become very easy with these so-called oral anticoagulants, these direct oral anticoagulant agents. So I think a huge sort of advancement in the management of thrombosis due to atrial fibrillation, then huge advancement in pulmonary embolism and deep vein thrombosis. Also, these are preventive medicines and all. But recently, they have also been used in coronary artery disease. So without taking much time, I think I will like to have the case presentations. Actually, this is based on the cases. And I'm sure this program is going to be very exciting because we have very, very eminent moderators who will really comment upon the presentations that we made. And therefore, without taking much time, I will request Dr. Navajit Talukar to present his case of coronary artery disease with thrombosis. Dr. Navajit Talukar. And then the moderators can take over. Yes, Navajit.
Sir, am I audible?
Yes,
Yes, sir. Yes, sir. You're audible, sir.
Oh, video
Yes,
is not coming. You have not enabled the video.
Sir, switch on your video, sir.
I can't see myself in your video. Anyway, allow me to share the screen and I'll share the screen. Am I free to share?
Yes, sir. You can share. You can share, sir, now.
Good afternoon. Good evening, Manchandra sir.
Yes, good evening. Good evening. I think it's very clear now. You can just zoom it, cover the whole screen. Yes, that's good. Excellent. Please start.
Well, sir, today I selected a slightly different case. It is a case of atrial fibrillation in elderly, which is considered one of the holy grails of modern medicine. Well, in the prelude, one second, sir. পাঠকবু আমি একটা টকে আছে একটু পরে করছি আমি রাত্রিবেলায় করছি well here was a 74 years female who was frail. According to modern standards, frailty index will be more than 30. Hypertensive, diabetic, hypothyroid. She had been a patient of chronic persistent atrial fibrillation with fast ventricular rate, was on rivaroxaban, and had presented to us with severe breathlessness and orthopnea. Query: there was a prior history of stroke or TIA 10 years back. No records were available. Clinically, she was critically ill. There was severe pallor, and she was on altered sensorium. Pulse rate was 160 per minute, irregular. There was absent A in JVP. BP was on the lower side, and she was on failure. Labs, we found that hemoglobin was 5.4 with a PCV of 21. Obviously, she has bled somewhere. She was also having a creatinine of 2.4 and a potassium of 5.4. She had raised sugars also. This was her ECG showing atrial fibrillation. And on echo, we found a moderately dilated LA of 33 to 34. The RA was mildly dilated and no other alarming features in echo. She needed to be ventilated, received 4 units of Paxil. Ultrasound abdomen revealed renal parenchymal disease and involvement was mild. Nephro consult and other consults were taken and she was married. Endoscopy, she had enteral gastritis, which was RUT positive. She was suffering from duodenal ulcer, Forest class 3, and hiatus hernia of heel grade 2. The gastro people put a sclerosing agent plus local treatment. No definite breeders were, however, identified. After 4 units of transfusion and conservative treatment, she had been put on subcutaneous low molecular heparin because with prior history of stroke and very high charge was scored, she had to be given some sort of stroke prevention. She was on ventilator for 13 days and was extubated later. AF rate was controlled to around 110 per minute. Now, this is a patient with high charge was score. She had already bled, also a high bleeding risk score, and in a dicey situation. Now, options were whether to go for oral anticoagulant or novel anticoagulant. Novel anticoagulant, she was already on rivaroxaban. The other choices becoming LA closer or Lariat device. With a mood to do an LA closer, we thought that we'll go for a LA appendage closer. We went for the transesophageal echo. Here I have an image of the transesophageal echo showing the capacious left atrial appendage, which was initially type 1 type. We all know that what are the 4 major types of appendage. This was a thumb type. Meanwhile, she had clinically better off inotropes, blood cultures were negative, LFT and RFT settling, bad lungs, there was a mixed restrictive and obstructive pattern, which we found in HRCT. So this is a video of the left atrial appendage closure being performed. We did a transeptal puncture. Here we can see the Mullins sheath into the left atria. We must remember that in LA appendage closure, we have to do the puncture slightly posteriorly because the LA, otherwise it is difficult to enter into the left atrial appendage. So you can see the picture here showing the position of the pigtail and the sheath is slightly offsetting than the usual course. Here after this, we took a stiff wire, entered into the right upper pulmonary vein. This is how it is done. And we take a pigtail from the left upper pulmonary vein. We slightly slit the pigtail, which usually entered into the LA. There we took an angio. Care must be taken that you don't put too much of a dye and not too much of a pressure, because there you can perforate the left atrial appendage area or the junction. So we can see nicely the appendage and its picture. This is, however, very different picture than the echo. Here, what we have to see the waist. We must remember that we have to put the device quite well in. We measured, and it was a 32. It was accommodating a 32 size with Watchman device. So this is further. We have to go deep inside the left atrial appendage. So with the sheath, we entered deep inside the appendage. Here at this point, if you see, we had some difficulty because if you see on the left side, upper side of the picture, you had a slight kink on the sheath. So how did we manage the kink? We reintroduced the stiff wire, and with a slight tug, we corrected the sheath position. And after correction the sheath position, we took the device, and with a very careful maneuvering, you go deep inside, select the waist, and slowly deploy the device. I think you can clearly see the device is being deployed, the barbs being released. Well, this is the stage where you do the tuck test. We did the tuck test. Then you should do a mild, gentle push. Here we are slowly pushing the device well inside the left atrial appendage. And then this is the final stage where you do the release. You can see the device nice and beautifully sitting inside the left atrial appendage, taking its contour. So here we had released the device. After release the device, you cannot retract it, but however, you have to take a small angio just to be sure that you have done everything is right. Concerned here, you have to see how much dye is going inside the thing, and if there is any over protrusion of the device into the left atria. So here the device was well centered, well fitted. So post procedure, now here comes the dicey situation. Even though patient has bled, you have put a device. So for a short time, dual antiplatelet is required, plus low molecular weight heparin. 2 days henceforward, she had developed breathlessness, and it was found that she was having bilateral pleural effusion. Left was more than right. Antiprogen pace quite high. She was on failure. Tapping was tried at night by a courageous resident, and he developed on a hydropneumothorax. So this is the HRCT. Then she had to be again intubated for a day. ICD means the intercostal drainage was done, and final this thing was done that there was a minimal pericardial effusion with a part of CHF. She gradually improved over past next 10 days. On the 7th procedure day, NOAC was added. This time we thought that because she had a GI bleed and rivaroxaban was bleeding, incremented her bleeding, and her frailty index, we decided on half dose of apixaban twice a day, along with others. Low molecular heparin was discontinued. Dual antiplatelet, aspirin and clopidogrel was given for a month. LFT, RFT normalized. Physio continued. She had a grade 1 bed sore which was healing. On the first 7th day of discharge, she was having weakness, was on wheelchair, hemoglobin was 10.8. On T, we saw that flow was reduced by around 30%. On 21st day, patient came walking. Echo showed minimal flow across the device. There was no evidence of device-related thrombosis. Hemoglobin has improved to 11.1. We had then planned a monthly follow-up at 6 months, NOAC plus DAPT for 1 more month, T after 2 months, and monitor clots, etc. plus flow across the device. Continued DAPT for 6 months and then out. So it is 4 months till now. She is already on a DAPT, and we had asked her to come back and follow up post Diwali when we will discontinue her DAPT. Thanks.
Thank you very much for your very difficult case presentation and all. I would request now the moderators, Dr. Rajput, to take over, please.
Yeah, I think very well done case, highlighting all the nuances of what we can go through in such critically sick patients. So I just missed, because of some technical problem, I just missed the first few slides. So was it the second stroke or first stroke?
No, she had suffered stroke around 10 years back, stroke or a TIA. This time, she had come with a GI bleed, heart failure, and near-death state. So we had initially resuscitated her, put her on ventilator. She required ventilation for 13 days.
And she has atrial fibrillation.
She had atrial fibrillation. The ECG we showed she had a chronic persistent AF.
Was she on some therapeutic doses of anticoagulants in between?
Yes, sir. She was on rivaroxaban, 20 milligram daily.
20 milligram daily. Okay. So I think the only discussion can be that, once this patient presented with such a high bleeding risk, and because after putting the device, again, we have to put her on anticoagulation and antiplatelets. So the only issue could be whether we could have tried different NOAC this time, which is more effective, or just go for LA appendage closure. And I'd like to seek opinion of Nagendra, if he's joined so far, what he would have done in this case.
I think, sir, this is a very nicely presented case, and this is a very good option. But definitely, what you are suggesting is also a reasonable option, that if patient is coming with a rivaroxaban, which is considered to be most prone to bleeding risk, then we can go to a drug which has less bleeding risk, especially GI bleeding risk has gone down if we use apixaban. So that is one of the choice. And considering her bleeding risk, we can try lower dose. So that is one option, because she has no stroke for last so many years. So risk of stroke definitely is not that high. So we can change the molecule, but considering her situation, she may not get a second chance. So this is, I think, a foolproof job what Dr. has done. And I think this is a very reasonable approach in very sick patient, that you close all the chances of any kind of embolism, because if she develops a stroke next time, she may not survive that. But definitely in a patient who is quite stable and coming to OPD with history of some GI bleed, we can definitely change the NOAC and try it.
Yeah, NOAC has been changed. She had been put on apixaban, as I've shown already on site. Only thing is, we have selected a lower dose of apixaban as per current guidelines, because frailty is there. So that is why we have selected 2.5 milligram twice daily.
And Dr. Talukdar, one more question. Can you just, for our benefit, tell the recommendation about what should be the ideal recommended antiplatelet and anticoagulation after LA device closure? For how much? For how many times dual antiplatelet, then single antiplatelet and anticoagulation?
Yeah, I want to highlight it. Actually, in Watchman device, we have many other devices. In Watchman device, it is mandatory at least for a month or at least for 8 weeks to give DAPT. Now, DAPT is required. Why? Because whenever you are putting the device, those the barbs of the device itself can be thrombogenic, like a stent. Okay, and as the flow gradually reduces, you are promoting thrombosis. So what happens is on the LA aspect of the device, there is a chance that clots will form. There is a new term for this, which is called DRT, and this is called device-related thrombosis. Whenever you are doing an imaging in such a patient, you are supposed to write how much flow has reduced or not, and if there is evidence of DRT or not. DRT they have defined as new haziness or new any structure forming within the device implanted or any mobile heterogeneous structure seen there. So there is a clear-cut guideline. If there is a DRT, then it is potentially a dangerous situation. To prevent this, you have to put the patient on dual antiplatelet agent. The recommendation current date is aspirin and clopidogrel. The dose of aspirin is the lowest dose what it can do. Clopidogrel also not, unlike the coronary, not even in hospital, not twice a day, but once a day. And you were to select a shortest course possible. So in device, if you keep on monitoring, so after 1 month or 8 weeks, you can take off the antiplatelet. There is a Watchman trial, Watchman का 2 trial है, तो उस trial में they had selected this, and according to this, the guidelines also recommended this. Now this is a dicey situation whether they have recommended that you monitor this patient very closely for evidence of bleed, and shortest possible time, maybe in 3-4 months, you reduce the thing. Whenever the flow reduces, your job is done. Where in first 1.5 months, the risk of DRT is more. You reduce the chance of DRT and then you take it off. So next, after Diwali, I'm planning to take off everything.
And what about the anticoagulation? Any specific recommendation about that?
No, anticoagulation in that period, we have done the entire exercise because we don't want anticoagulation for a longer period of time. So once the appendage is gone, you don't require anticoagulation at all.
But you have put your patient for almost...
in Medanta, we did a similar case. There was intracranial bleed in that patient. That patient would have died. So we allowed the patient to settle for some time. Then we did an LA appendage closure. And after that, we put him on only 1 month of aggressive treatment. In that case, we did only low molecular heparin plus DAPT. And then that was around 2.5 years, 3.5 years back. So at that time, the guidelines have not been done properly. It was based on small record, but that case we did it that way.
But in your case, how many weeks did you give anticoagulation plus DAPT?
That is 6 weeks.
So did you modify the dose of anticoagulation because in a patient who recently bled?
We already did 2.5 milligram twice daily.
So for 6 weeks, she was on apexaban 2.5 twice a day with clopidogrel.
Yes. I want to highlight that we face this kind of situation very, very frequently. Now, the understanding and this thing doesn't allow us of going too much in favor of LA device, because the device usage, one, it is very costly. The usage of the device is less in India. I want to highlight that these options should be thought of. At least we should keep these in the horizon of our thought so that we can use it in a better way.
I think just one small comment here. Now the new device is coming. So the problem with this device is that there is a screw which is used to anchor this with the deployer cable, that is one point where the clot forms. And generally, if it is too deep, there is some shelf made at the origin or at the mouth of the appendage where the clot can form. Like it was there in this patient also, that there is some shelf because the device is slightly deep on one side because you can't control the position of device. So for those situations, till endoscleration happen, we have to give anticoagulation. So that is one thing which is a drawback in this situation, but definitely there's no other option for that.
Yeah, that is why what I did, that is why you must notice, I did TE guidance every 15 days.
Yeah. So the new device is coming, which has the screw which is inside, and the position is also changed. So even for the smaller appendages, it can be used, and it has no screw outside. So many more advantages in terms of the barbs are also less. So chances of pericardial effusion also less. So once the device, so it is available commercially now in other countries, but it's not available in India. Possibly it will come by next year, and it will definitely help in deploying it much easier, and the control of DAPT will also be easy.
Another point why I brought it in the forum is surprisingly when this patient shelled out entire thing from her own pocket. Surprisingly, when I sent a letter of this thing from the ECHS and subsequently CGHS, I found out that they were not aware of the entire thing. So, these things needs to be corrected, at least in our country. People have to be aware at least that such treatment exists. And at least we should be accepting from the CGHS and ECHS. Now they have written us, you develop guideline and tell us. Now this is the situation.
Yeah, Dr. Aludar, just two more small things. Presented with second stroke, was there a MRI? Was there a infarct?
Sir, she did not present with the second stroke. She presented with failure, acute decompensated heart failure, because precipitated by anemia, because of GI bleed.
Okay. And when you did your first T, was there any visible clot in LA?
No, that I've shown. LA was clear. The left atrial appendicular emptying velocity was 40. It was less.
I think very well done case, and I would request Manchanda sir to give his final comments about this case, and we can move on to the next one.
Yeah, I would agree. This is a very challenging case and a very bold decision taken to treat this patient. Firstly, this patient, as he said, it was very frail. There's no data on frail patients, neither on oral anticoagulants nor even in the devices, because these patients are excluded from the trials. But as he said, I think we must keep this option. This is an option which is available when anticoagulants are not there. But I would say very, very bold decision. Many people in this country will not do that because this patient is having already renal failure, which I see is a stage 3 or something like that. And then to give this, even to do some injection with the dyes, it may get worse and all that. Patient is also in failure. And I think they have taken this bold decision. And secondly, to give these patients, dual antiplatelet and oral anticoagulants sometimes becomes a problem because the patient has a bleeding tendency. There were ulcers which of course have been ligated, etc. and all those things. But I think very well done. I think we have to take bold decision. Individual cases, the guidelines may not help us. And as he said, the other alternative could have been to use a small dose of apixaban. Apixaban has been tried in patients who had even bleeding, and there are studies available that patients who had bleeding, the only studies are available, apixaban, and is at 2.5 milligram twice a day is good enough in this patient because 2 of the 3 features were present in this patient. The weight has to be less than 60. They have to have renal failure more than 1.5. And thirdly, that so all these things were there and 2.5 milligram. Only thing is, yes, in such a case, I was wondering if you really like to give dual antiplatelets with the anticoagulants for really long period of, you should give very, very short period of time, because patient has a bleeding tendency and he may not bleed. The patient, of course, has not bled and all. But I think a very bold decision and very well done. I must compliment the team for taking this bold decision. But as he said, I think we should be aware that such treatment is available, at least in some centers. We should not give up hope at all. But as the other alternative was suggested, that one could have given only apixaban 2.5 milligram and results could have been possibly similar. We don't know that, but at least this gives a lot of satisfaction. Only thing I would like to say is a study which shows that even after this device, the embolic episodes may not reduce too much. So one possibly has to give them for a long period of time, these oral anticoagulants. There's a recent study which has come up which shows that it's not a very positive side about these devices. They are there for quite some time. And yes, of course, they are very encouraging. Patients who cannot take anticoagulants can be given. But again, I think very well done, very well presented, and the results are excellent. So congratulations to you, Dr. Talukar, for this excellent case.
Thank you, sir. I remain indebted. Keep your blessings.
Yeah, let's move on to the second case now. And Dr. Harshin, will you be presenting the second case?
Very good evening to everyone. I'll start sharing my screen. Just a sec. Just a second. I think there are some preferences which we have to clear before we can start sharing. Just a sec. Yeah, I got it. I think I'll have to. Hi, sorry for the disturbance there. I was not able to share the screen. I think now I can. Yeah, is my screen visible now?
That's visible.
Yeah, it's visible.
Okay.
Quite clear now.
Yeah, just a second. Yeah, so I think I'll go ahead with the presentation. First of all, congratulations to Dr. Talukdar sir for managing such a complicated case with high bleeding risk with Watchman device. In continuation with that case, I'll go ahead with my presentation. There's a one sec. There's a screen on my the videos are being still coming on my right side. I'm not able to see my entire. Okay, yeah, that's better now. Yeah. So with this case, contrary to the previous case, has a very high ischemic risk, and we'll get to see how every AF patient is different. It's a very heterogeneous disease, and we have to individualize our treatment options with every single case. So this is a case of HOCM with atrial fibrillation. Yeah. So it was a 52 years old female who was a known case of hypertrophic obstructive cardiomyopathy post dual chamber AICD insertion, which was done at another center. And she had a long standing AF with fast ventricular rate. She was on treatment with beta blockers and dabigatran, 150 milligrams BD. And she came to us for routine follow-up. And while we were doing a routine echo, she developed sudden onset right-sided hemiplegia and with aphasia. She realized she cannot move the right side of her body at all, and she cannot speak as well while undergoing 2D echo. And she was admitted for further evaluation and workup. At examination, she had a GCS of E4, V1, and M6. She had right hemiplegia with power of 1/5 in both right upper limb as well as lower limb. She had global aphasia. NHS score was 20. Her vitals were stable, and thus a diagnosis of left MCA syndrome was made. She never had a stroke previously, and she never had any disability. So her pre-stroke modified Rankin score was 0. So what next? The patient has developed an in-hospital acute left MCA stroke with global aphasia, which looks like a proximal artery occlusion. So let's look at the guidelines. Let's look at the 2019 update to the 2018 guidelines, AHASA, for the early management of acute ischemic stroke. So the guidelines say that if the patient is eligible for IV alteplase, the benefit of therapy is time dependent and treatment should be initiated as quickly as possible. This patient developed stroke inside the hospital in front of us. So she was definitely a candidate for IV alteplase in that regards. However, the guideline also says the potential risk should be discussed during assessing IV alteplase eligibility deliberation and weighed against the anticipated benefit during decision making. So you have to always assess whether the patient is a candidate for IV alteplase or not. So this is again time window within 3 hours. It should be given as early as possible. Now coming to the eligibility recommendation for IV alteplase. So all of these criteria within 3 hours of the patient is presented. Yes, patient has severe stroke. Yes, NHS score is 20. But the patient is on dabigatran. So if the patient is already taking a thrombin inhibitor, direct thrombin inhibitor, what the guidelines say is IV alteplase should not be administered to patients that are already taking direct thrombin inhibitors or direct factor X inhibitors unless lab tests such as APTT, INR, platelet count have been proven to be normal. Since we cannot do these tests on emergency basis, our patient is clearly not a candidate for IV alteplase. Again, all European, US as well as Canadian guidelines say that the patients who are receiving oral anticoagulants are not candidate for IV alteplase. So what is the next option? Mechanical thrombectomy. So let's see what the guidelines say. Patient eligible for IV alteplase should receive IV alteplase even if mechanical thrombectomy is considered. So any patient who is eligible for it, the first choice is always IV alteplase. However, our patient is not. So coming to the guidelines for the mechanical thrombectomy, direct aspiration thrombectomy as a first pass mechanical thrombectomy is recommended as non-inferior to stent retriever for patients who meet all the following criteria, and it's a class 1 indication. Pre-stroke modified Rankin score 0 to 1, ours is 0. Causative occlusion of the internal carotid or M1, ours is also left MCA with segment, we are not sure yet. But it definitely looks like a large vessel occlusion because global aphasia is there. Age is more than 18 years, yes. NHS score is more than 6, yes. Aspect score is more than 12 to 6, which we'll get to know after doing the CT. And treatment initiation can be done within 6 hours of symptom onset. Yes, in our center, we can do it within 6 hours. So coming to next recommendation, although the benefits are uncertain, the use of mechanical thrombectomy with stent retrievers may be reasonable for carefully selected patients with acute ischemic stroke in whom treatment can be initiated within 6 hours of symptom onset and who have causative occlusion of the MCA segment M2 and M3. Use of stent retriever is indicated in preference to the Mercy device, which is class 1 indication, and the technical goal of thrombectomy is TC grade 3 or grade 2B. So what we did in this patient was, this patient had she had a NOAC use recent. She took her NOAC dose the same day as well, and she had a large vessel occlusion. So she was planned for mechanical thrombectomy. So we took her to the cath lab. We have a very good neurointerventionalist in our center. So with his support, we took the patient for mechanical thrombectomy. So we ruled out bleeding using a DynaCT in the cath lab itself, and the family was counseled in detail regarding the diagnosis and treatment options along with prognosis. Patient underwent immediate DSA with mechanical thrombectomy for the left proximal M2 occlusion under local anesthesia to right femoral root. So this was the CT scan which we did at the in the cath lab itself. So as we can see, this was done just to rule out the bleed. There was no bleed. So we went ahead with the angio. So this was the first angio which we got, and we can see that. So this is the internal carotid artery going. This is the MC over here. This is the ACA. This is the M1 segment. This is the M2 segment, and we can see a small thrombus sitting over there. This over here. I have my pointer is visible. Again, done in sagittal view. Same. We can see there is a thrombus sitting at the M2 segment. There's a clot sitting at the M2 segment. So we went ahead with the mechanical thrombectomy, and this is the 0.014 PTCA wire, which we've inserted into the MCA, the wire going up. After wiring, we took another shot just to confirm the wire position. And then we put the wire all the way up to the MCA, to the distal part of MCA. And then we have a micro catheter over there. This is the Sophia aspiration catheter. And along with that, we have a Headway 21 micro catheter. After crossing the micro catheter, we've removed the wire. And over the micro catheter, we've inserted the Solitaire X stent retriever. It will be coming now. Yeah, this is the stent retriever coming up with the three radiopaque points at its distal tip. And then we removed the microcatheter, and that led to the opening of the stent retriever. After that, so this is the removal of the microcatheter. The microcatheter is coming down, coming back. The stent retriever has been left opened inside the MCA. And then we take a shot which shows a large clot inside the MCA. And then we take out the aspiration catheter along with the stent retriever, which takes out the clot with itself. And then we take a final shot, which shows a good result, a TICI3 recanalization. And then we do a final CT again in the cath lab itself. This is the final CT, which is done at the cath lab. This shows the contrast staining of the MCA territory. This is not a bleed though. This is just a contrast staining. And so what seemed to us was a happy ending. There was a good result with a TICI3 recanalization. Patient improved on table with NIHSS dropping down to 0. Patient could speak. She could move her right upper limb as well as lower limb. So it seemed like a good ending to us. And then she was shifted to ICU. Repeat NCCT did not show any bleed. She remained stable over the period of next 3 days, and she was maintained on anticoagulants. So this was the repeat CT. So there was this one old chronic infarct in the left posterior cerebral, but it was a chronic infarct. And the acute infarct MCA, there's this contrast staining still, but there's no evidence of any bleed, and the patient had been doing well. But after 3 days, the catastrophe started. Patient's sensorium suddenly deteriorated, and she developed signs of raised ICT. Repeat NCCT was done, which showed right pica territory infarct with significant mass effect. So this was the repeat NCCT which was done. And she developed a huge infarct in the right pica territory, and she had hydrocephalus with raised ICT signs and midline shift as well. Urgent neurosurgery consult was taken, and she underwent posterior fossa decompression with modified lateral supraorbital approach and underwent legs duroplasty with external ventricular drain through the right coccus point. So repeat CT scan done next day after the craniotomy showed some resolution of the hydrocephalus. Then we did one more CT, one day, another after another day, which again showed the right pica infarct, a left chronic infarct, and resolution of the hydrocephalus. Another CT after removing the drain, which showed slightly better findings. Hydrocephalus is still there, but it's resolving. So it was indeed a real happy ending. After that, the patient underwent right VP shunt, because there was still some hydrocephalus over there and raised ICT. She was discharged on the 7th of June in stable condition and in sinus rhythm. Surprisingly, she self-reverted to sinus rhythm at this point of time. And at follow-up, the patient is on metoprolol 50 milligrams BD with apixaban 5 mg BD, and she continues to be in sinus rhythm. So this opens up Pandora's box, as if we could have controlled the entire catastrophe which happened just by if the patient could have been reverted to sinus rhythm earlier. So what are the guidelines as of now? These are the 2020 ACCHA guidelines with about the rhythm control for atrial fibrillation. The guidelines say that evaluate if the patient has symptoms or not related to AF. If symptoms are absent, then exclude unconscious adaptation to reduce physical activity, restore sinus rhythm by cardioversion to evaluate symptoms, and evaluate if the symptoms are AF related or not. And if the symptoms are present, then assess the following factors. What is the age of the patient? If the patient is younger, patient goes for rhythm control. If it's a first episode of AF, goes for rhythm control. If the patient has developed cardiomyopathy related to AF, goes for rhythm control. If the patient has normal LSIs or moderately increased LSIs, goes for rhythm control. If rate control is difficult to achieve, goes for rhythm control. And if AF is precipitated by a temporary event like acute illness, the patient goes for rhythm control. And if more of these factors are prevailing, patient goes for rhythm control. If less factors are prevailing, rate control. So what is important to know here is that this is a study done in 2004, which showed that antiarrhythmic drugs, they have significant toxicity. And compared to achieving sinus rhythm, the all-cause mortality is more in patients who are receiving antiarrhythmic drugs. Remember, there are multiple studies which have shown that ablation is more effective than antiarrhythmic drugs at controlling AF, at preventing recurrence of AF. Cabana trial also showed that even though it did not show any mortality benefit, I agree, but it showed that the recurrence of AF events are much lesser in the ablation group, and a cost benefit analysis wise also ablation group does much better. Ablation is more effective than antiarrhythmic drugs at improving quality of life, again shown in Cabana trial, Cryofirst trial, the recent 2 trials. So ablation is more effective when performed early, as AF is a chronic progressive disease. So always remember, in early stages, isolated electrical problem is AF is just an isolated electrical problem due to rapid firing from focal sources. But in later stages, it becomes a structural problem, which is resulting from oxidative stress, inflammation, and atrial fibrosis. So whenever we are thinking of atrial fibrillation treatment, remember, anticoagulation does not eliminate strokes completely, like in our case. Antiarrhythmic drugs have significant toxicities. Ablation is always better than antiarrhythmic drugs for controlling AF, and ablation is better than antiarrhythmic drugs for quality of life. Ablation is more effective when performed early, before structural remodeling occurs. Even though there's no mortality benefit as such, still till date we do not have data, but we do not have sham control trials, so we cannot be really sure. But it looks like ablation does well for cost analysis as well as quality of life. Thank you.
Thank you for your very, very interesting case and telling us if a patient develops stroke. A patient can develop stroke even on so-called the NOVAX and all that thing, and how to manage that. Very difficult case, as you said, and the patient initially improved, but later on. I just wanted to ask you, was the patient being given these oral anticoagulants after the thrombectomy that you had done or thrombosuction you had done? Or sometimes the neurologists say that don't give anticoagulants for at least a couple of days or 3 days after an infarct. So were you continuing it, and what do you think was the cause of this bleed?
We were continuing heparin after mechanical thrombectomy. We stopped the oral anticoagulants, but heparin was continued.
Only
and yeah, there was no bleed. The hypertense areas which we saw that was contrast staining after the intervention.
Mm-hmm. I think I will ask the moderators to take over. Very interesting case.
I think Dr. Bhatia, was this case done recently or?
It was done in May end this year.
So this patient was on dabigatran.
Yes, sir.
So why was not reversal agent considered?
She was under follow. She was diagnosed as a case of HSM at a different center, and she was on follow up at a different center. This time she presented to us for the first time, and she just came for she had a change of place, so she started following up with us for this first time, and she just came for routine follow up. She had never experienced stroke before. She never had any TI before.
What I mean that when this patient was in hospital, and as you rightly picked up the point, this stroke within few minutes, and right. She was on this patient was on dabigatran.
Right.
So you can reverse this dabigatran in 10 minutes, and then you can thrombolize. There are various case reports of thrombolysis after reversal, because this reversal agent reverses everything in 10 minutes. And then you could have there could have been an option of using standard thrombolytic agents rather going through a very challenging mechanical thrombectomy, because mechanical thrombectomy, as per my understanding goes, is only restricted for those patients where thrombolysis cannot be done or has failed.
Another reason, first reason is of course non-availability of idarucizumab, which we did not have at that point of time. And second thing is it was a large vessel occlusion. Patient also had NIHS score was 20. Patient had global aphasia along with right hemiparesis. So in these conditions, mechanical thrombectomy is also equally indicated as per the guidelines also which we saw. Mechanical thrombectomy is a good option here. And the patient actually did well with mechanical thrombectomy after that, but unfortunately she developed another territory infarct 3 days later, which could not have been prevented even with IV thrombolysis. So
I think mechanical thrombectomy is a much more complicated, much more demanding procedure, and is associated with, there is, if I remember, there is a definite recurrent stroke risk, procedure-related risk, which happens in first 48 to 72 hours. And this looked like your patient had, despite being on heparin infusion. So
but the patient had stroke in a different territory. Patient had it in, the intervention was done in the left MC territory. Patient had stroke in right pica territory later on.
Otherwise, excellent case, and patient did well finally. All that ends well is well. But sir, would you agree with this reversal agent option?
Yeah, I would agree with that because thrombolysis has much more data, and this they were very successful in this mechanical thrombectomy. But that's much more challenging and all that. I agree with you, but they said that it was not available. If it is not available, then you have no other option. I think their option was correct, but it is available now with the company very quickly. They can give it. They say if one contacts them. So fortunately, that reversal, that would have been a better option. I agree with you completely. After reversing it, one could have given thrombolysis, and then it might have been better.
Right.
Nagendra, any comments?
I think no, sir. So the case is very well presented, and what they could do is they have done all those options, and the problem is recurrent thrombosis, because once you are doing mechanical thrombectomy, there is a risk of spasm and there is risk of rethrombus. But in this case, this was from another territory, so possibly the AF is the culprit which was causing this problem. So I don't think for that they have any option because they are already on anticoagulants. So there are some patients who don't do well. They even, like, we have many patients who are coming for angioplasty. We have done angioplasty, given blood thinners, and on next day they develop thrombotic stroke. So I think once or twice a year we are seeing these kind of situations, not an embolic or bleeding stroke, it's thrombotic stroke. So some patients are so thrombotic that you can't help them. Whatever you do, they have high risk of thrombosis. So like in this case, he developed second thrombosis. So I don't know what is the long-term solution for them, because even this ablation for AF is also not, like, the success rate is just 70% and recurrence rates are quite high. So you can't rely on that. So the patient still has to be on antiplatelets. So with that, do we recommend, like now they are coming with this new idea that you should embolize the L appendage, close the L appendage and give half dose anticoagulation still with after closure of L appendage. So this is one of the options. I don't know how feasible it is. Possibly new more data is required for that. So we'll see.
Right. So surprisingly, our patient, she reverted to sinus rhythm after everything. So I don't know what it takes for a patient to get it, whether it takes a mechanical thrombectomy and a craniotomy for the patient to revert to sinus rhythm.
No, she must be paroxysmal atrial fibrillation. You see, that's quite right. Are you giving any antiarrhythmic drugs? Because she obviously has paroxysmal atrial fibrillation. It's not persistent.
Yes. We've continued her on 5 mg BD of apixaban now.
Yeah. And no, any like Corderone or something like that. Are you giving it to sustain? Because she's
50 mg BD and
she's likely to go to atrial fibrillation again sooner or later. Because
she's on 50 mg BD of metoprolol. With that, her sinus rhythm is maintained as of now.
No, I said that is all right to reduce the rate and all, but to see that it sustains in sinus rhythm, some other antiarrhythmic, like Corderone might have to be given, something like that, which can sustain it. Like after cardioversion,
she also has an LVOT gradient of 60 millimeters of mercury, So that is another consideration. So for that effect, beta blocker is a very good drug which reduces the gradient.
Beta blocker she must get. There's no question of it.
Yes, yes.
There's no I think doubt about that. Right.
So you prefer flecainide or you prefer Cordron? Because Cordron has multiple side effects in long run. So what you prefer in a normal LV patients? Like in this patient, definitely there's structural problems, so you can't use those other anticoagulants. But in a normal LV patient, what is your preferred choice?
Yeah, normal, I would prefer flecainide in a normal LV function. But this is an abnormal LV function.
Yeah, so in this,
in this hypertrophic cardiomyopathy, I have several patients of hypertrophy. In all them, I'm using Cordron. Of course, small dosages and all. And sometimes it maintains the sinus for a long period of time. If you're given a small dose, the side effects are very minimal. Of course, in high doses, Indians tolerate the small dose, it seems, quite well. Say up to 200 milligram or something like that. So, yes, any other comment? We had very nice presentations and all that thing.
So I would request you to just conclude and summarize. We had very good discussion, as you rightly said. So just
yes. I think, friends, you will agree with me that this was a very, very interesting and an academic session. 2 cases were presented and both were very, very challenging. I think very few of us will do what has been done. So as it was said in the first case, the patient had atrial fibrillation and was frail and all sorts of comorbidities. Never give up hope and try to do the best possible. And if a center is good in doing this LA occlusion devices, it's a very good result. So I think a very, very excellent case. The first case was, I think very few people have done it. And congratulations to Dr. Alukar. The second case is equally interesting, that it shows that all patients who get anti sort of coagulants, still they can get embolic episodes and all. And if a patient comes with acute stroke, it becomes really a challenge what to do with this, because they go to the neurologist and neurologists sometimes say you stop anticoagulation and so on. This is going on. But I think it was very well done. They did not have a reversal agent, otherwise that might have been the best policy, but they did the thrombectomy, which was successful. Unfortunately, the patient developed another stroke. We do not know the reason for that, whether atrial fibrillation or some hemodynamic instability, etc., which caused it. But yes, the patient can always develop a second stroke and all. And I think the end result was extremely good. They also did not give up hope. They did all sorts of, they did a ventricular shunt, etc. And ultimately, if you go on, I think utilizing these complicated procedures, these neurointervention procedures in such cases, it shows that the results could be very good. I think both cases show that these recent interventional procedures like LA occlusion device and also doing thrombectomy or putting a stent in the cerebral vessels could be very rewarding. So congratulations to both these speakers. And you would agree that we had a very nice discussion by the most eminent moderators and all, and they gave us a lot of information. I hope you have gained a lot from this. I have, of course, at least gained a lot from these 2 cases, which were most unusual and tackled beautifully, although with very modern, significant techniques. Thank you very much for your patience.
Thank you, sir. Thank you so much. Thanks to Dr. Manchandani sir for really hosting very well, and thanks to our moderator Dr. Rajiv Kumar Rajput and Dr. Nagendra Singh Chauhan sir, as well as our speakers Dr. Navjit Talukdar and Dr. for a really very insightful presentation, very insightful discussion, and definitely it got very lot of benefits to our delegates, those who joined today. So I would like to inform all of you that more than 300 doctors have joined today. Specifically, only North Zone we have telecasted this live presentation, and good discussion, good insights. And thank you so much once again from behalf of PEMQ. Once again, thanks to Manchandani sir and all our faculties. Thank you, sir, and good night, sir. Good night. Thank you.
Thank you very much.
Good night, sir.
Thank you, Dr. Bhatia. Thank you, Talekar and Rajput. And yes, thank you, Nagendra.
Good night, sir. Good night.
Good night.
Good night.